abnormal eye movements. So as someone asked earlier, is it possible? How do they do it? It's by suppressing. So I don't know how many of the class can do this. So we test conjugate gaze, as I showed you earlier, using your fingers, asking the patient to follow it, ask the patient to look to the right, ask the patient to look to the left, ask the patient to look up on the side. So you flip the finger so that it's horizontal when you're testing the vertical gaze, and down here. So this is how you test for a normal horizontal and vertical gaze. And then you do the same on the other eye. Going up, going down. Then you go back to the midline, test up gaze and down gaze. So this is a way to test for the cardinal eye movements. Okay, and that's how we test for horizontal eye movements. And this is the basis for the double H in testing for extraocular muscles. So if you have conjugate palsy, like in this case, so ask the patient to look to the right, ask the patient to look to the left, but there seems to be a preference on primary gaze. They seem to deviate, they deviate to the right side of this patient. But the horizontal gaze is intact when you ask them to look either right or left. So same thing, you ask them to look up and down on extremes of gaze using your double H. Things look normal. Same thing, when you look up and down, things look normal, but just at the primary gaze, they tend to deviate to the one side. So this is called conjugate gaze palsy, meaning it disappears when you ask them to follow your fingers. So this just described as preferential gaze to the right. Okay, so going back to our examples, so it just means one of our frontal eye fields is not working. So usually, the tone is normal, meaning right and left are both equal in strength. Therefore, your primary gaze is midline. But if one side is weak, like your right frontal eye field has a problem, then the left frontal eye field will predominate for a little while, causing a preferential gaze to that side where there is a problem. So this is a sign that if the problem is in the brain, in the cerebral hemispheres, a right frontal eye field lesion, the patient will tell you by looking to the side of that lesion. It's a clue from the patient. But that means they should be able to follow your commands. And there's nothing wrong with the gaze centers in your brainstem. There's nothing wrong with the PPRF, as you can see from that examination findings. There's nothing wrong with the MLF as well. Okay, so preferential gaze. Another type is a forced gaze, conjugate gaze. So baseline, they're looking to the right. On looking to the right, they look to the right. But if you ask them to look to the left, they're still looking to the right. No matter how hard they try, they cannot force their eyes to look to the left side. So it's conjugate, meaning they're both in the same direction. There's nothing wrong with the yolks. You ask them to look up and down on that side, it's okay. Ask them to look to the left, they still cannot look to the left, but they can look up and down. Same thing with the primary gaze. Looking up and down, it's deviated to the right side. So this is what we call a forced gaze palsy, meaning the eyes do not cross the midline if ever. They're forced to one side. So we describe this as a gaze deviated to the right, not overcome by your maneuvers. Okay, what happened? So illustrating again the tone. There are equal tone from both cerebral hemispheres in this normal case. But in a forced gaze palsy, it tells us something is wrong in the brainstem. So this it distinguishes itself from the earlier example where the problem is in the cerebral hemispheres. If it is a gaze problem from the PPRF within the brainstem, it means that left gaze never could be initiated. So there's no gaze at all to the left side. The patient could not do it because of a problem here in the PPRF of their abducens on that left side. So what happens here, this time, the eyes look away from the side of the lesion. Here on the left, the eyes here are now forced to look at the right in a pontine gaze lesion. And the internuclear ophthalmoplegia I illustrated earlier. Okay, on looking to the right, the left eye doesn't follow, and this persisted across the different maneuvers that you did, the double H. So this is a simple I&O, where the right eye, the right 6 was disconnected from the left third over here. Okay, on an internuclear ophthalmoplegia on that side. Okay, so this is just a review. It's a problem in the MLF if there is the patient is unable to follow. Okay, so it's an MLF problem. Bilateral internuclear ophthalmoplegia is found by making the patient look on the extremes of gaze. So this is what happened on gaze to the right. The left eye didn't follow. Gaze to the left, the right eye didn't follow. Definitely you have gaze initiation because your sixth nerve is working both sides. So this is your bilateral internuclear ophthalmoplegia. Okay. So the problem is on that side where the MLF didn't follow. So here it's a bilateral MLF. So it's the yoke again that is being referred to here. A problem in the both MLFs to cause that kind of problem. A bilateral INO means a bilateral MLF. So INO should be synonymous for you by this time for an MLF problem. Okay, what about the 1.5? We're just illustrating it again here. Gaze to the right. The left eye didn't follow. Nothing happens on gaze to the left. Looking upwards, looking downwards, it's really just horizontal gaze. So that's your 1.5 lesion, because there's nothing wrong with your vertical gaze pathways. If the Dr. Batikalon has already mentioned it, or he has an upcoming assignment on it, the diving bell and the butterfly, now you know what's going on. Okay, so that's a 1.5 on the side of the one eye that is not moving at all. Okay, so a problem with the yoke on one side plus a PPRF problem. Okay, so the 1/2 is due to the MLF, the 1 is due to the PPRF 6 problem. Okay, what if it's just a LR palsy? So this is notorious, this can be confusing, and it's non-lateralizing when you get it. Here, this patient on primary gaze, the left eye is deviated towards the nose. You checked for right lateral gaze, no problems. You check for gaze to the left eye didn't move, it's still deviated inwards, but the right eye was able to move. This tells you one thing. The pontine reticular formation is working on that side. For this eyeball to follow, the MLF must have been spared. So if the PPRF, cranial nerve 6, is okay, and the MLF is okay, then the problem could be just here at the muscle and the abducens nerve itself controlling that LR. So it's a peripheral type of problem involving the abducens nerve, or a problem in the muscle. Okay, you did the maneuvers, nothing wrong on gaze to the right, up and down. The patient was able to look up because that is a function of the obliques, which are controlled by your third nerve. it's really just horizontal movement of that eyeball that was compromised. So it's a purely isolated lateral rectus palsy. Okay, on the left. So it's anywhere where the abducens nerve left the brainstem to the eyeballs, which is a lot of stations there. It could be at the level of the clivus, or it could be anywhere in the superior orbital fissure. So that's your sixth nerve going to the Dorelius canal, into the dura, into the cavernous sinus, into the superior orbital fissure. So a lot of places where you could find it. That's why a lateral rectus palsy is non-localizing. So that's the superior orbital fissure illustrated for you using a skull. And that's your lateral rectus, which moves your eyeballs to the lateral aspect. Okay, so these are just the stations where you could compromise the sixth nerve, anywhere from the brainstem, clivus, cavernous sinus, superior orbital fissure, to the eyeball itself. So in this case, it was a lateral rectus palsy on the left side. So L is for left, R is for right. The legend I'll show you later. So what about an isolated medial rectus palsy? So primary gaze, the left eyeball moves to the lateral. Gaze to the right, the left eyeball didn't move. So you have to suspect, is this an INO or not? On gaze to the left, no problems. So you have to differentiate now. Is this an INO problem, or is it just an MR, a medial rectus problem on the left eye? You will see. On gaze up and down, okay, there on the right. Gaze up and down on the left, okay also. So for the gaze, for the eyeballs to move laterally, that means the MLFs are spared. It's really just the muscle here in the left, in the left eye. All gaze directions, it's just this. I cannot look to the left side, to the right side, meaning it's an isolated medial rectus problem, probably in the muscle or to the nerve specifically for the medial rectus, a branch of the oculomotor nerve. So the nerve that controls the medial rectus by itself. Okay, so demonstrating the third nerve, they're using the same principle. It enters the dura, enters the cavernous sinus, and exits the skull via the superior orbital fissure. And then this is the map where the different muscles are illustrated. The only problem was in the left MR. So just a nerve to this particular muscle was involved. So the convention here is gray means something happened only to that particular nerve. Okay, so a more common finding, so this is a lot easier, is a complete right oculomotor nerve palsy. So gaze to the right, okay. But looking ahead, the eyes are looking in different directions. Gaze to the left, the eye moved a bit, but it cannot go past that point. Meaning there's something wrong with one of the nerves. But the only way to check is using the cardinal movements of the eyes. So when you look to the right and up, this eyeball on the right doesn't seem to be able to look upwards or downwards. It's stuck there. On looking to the left, it also cannot seem to look up, but looking down is no problem. Now, if you remember the trochlear nerve, the superior oblique, SO4, the clockwise action of the right eyeball, meaning towards the nose, is intact. Meaning everything else on the right eye is not working except for the superior oblique and the lateral rectus. And the final arbiter, so this tells us the problem is in the right eyeball, involving all the muscles of the third nerve, meaning the LR and the SO were spared. And you notice there was a drooping of the eyelid on that side. So a very drooping eyelid on the right eye. And the clincher is the size of the pupils, which are large and poorly reactive. So this is a sign you're dealing with a right third nerve problem. This is the so-called complete right third nerve palsy. The pupils gives it away. Okay, so where is the problem here in this map? So a right eye problem, a right third nerve problem. All of the branches of the third nerve were compromised, even the one that constricts the pupil. So that's where the problem was. So where could it be? It could be anywhere from the midbrain to the orbit. So right oculomotor palsy on the right side. Okay, so anywhere. So illustrating to you what happened here, this is the right oculomotor, this is the right orbit here. If it's a superior oblique problem, I've shown you this example already. So apparently on horizontal gaze, no problem. Vertical gaze to the right, no problem. Vertical gaze downwards for the right is problematic. It cannot seem to go down to this direction here. So that means the right eye is deviating upwards and towards the nose. Tells you that the superior oblique is not working on the right eye. So you complete your maneuvers and you see it's really just the intorsion, meaning the rotation of the eye towards the nose and down is absent. So this is a isolated superior oblique weakness. So meaning the fourth cranial nerve, which crosses here in the dorsal aspect of the midbrain, travels all the way to the eyeball. So anywhere peripherally, due to the size of the structures here, it's impossible to occur on its own. So following the trochlear nerve, which is tinier and thinner, into the dura, into the cavernous sinus, into the superior orbital fissure. So where is the problem? The right SO has been compromised, meaning the right trochlear nerve was compromised. Okay, so you put it all together in this map of the peripheral automotor system.